Mrs. Ladnier, the conference has begun.
Good evening, everybody. My name is Karen Ladnier, and I'm the Director of Research and Education at the Kerlan-Jobe Institute. And on behalf of Cedars-Sinai Kerlan-Jobe Institute, I want to welcome you to tonight's webinar. Cedars-Sinai Kerlan-Jobe Institute is excited to partner with the Long Beach Marathon as the official orthopedic and sports medicine partner of the Long Beach Marathon through fall of 2023. Tonight's webinar is going to focus on anterior knee pain in runners and will feature Dr. Joshua Scott from Cedars-Sinai Kerlan-Jobe Institute. After the presentation, we'll open it up for questions. And during that time, if you do have a question, we ask that you type your question into the chat box. We're going to go ahead and move on to the program. I'd like to introduce Dr. Josh Scott. Josh, if you want to go ahead and start sharing your slides. Dr. Scott is a board-certified physician in primary care sports medicine. He received his medical degree from the Medical University of South Carolina, where he also completed his residency in pediatrics. Following residency, he completed a fellowship in primary care sports medicine at the University of South Carolina. He's been in practice for almost 20 years and has been with the Kerlan-Jobe Institute since 2018. Dr. Scott has worked with the U.S. track and field team at the Olympic trials, as well as the U.S. championships, and serves as the primary care physician for the LA Galaxy. Additionally, he knows quite a bit about the physical challenges faced by runners, as he was a very talented Division I decathlete at Clemson. So with that, I'm going to go ahead and turn things over to Dr. Scott.
Thanks, Karen. I appreciate the introduction, and hopefully give me the thumbs up if you can see my slides and hear me okay.
Yep, we can see and hear you great.
All right. So yeah, I first of all want to thank the team with the Long Beach Marathon for allowing us to do this webinar tonight. I really appreciate the opportunity to come and talk with you, and certainly want to thank Karen and Rob Alvarado for help setting this up. Usually when we do these talks, we give disclosures to our peers to make sure that we're not, being paid by a big knee brace company. I don't have any good disclosures for you other than the fact that I was objectively a terrible distance runner. In college, I was much better sprinter and jumper. So my hat is off to anybody who can run a half or a full marathon, because I was never that good. 1500 was about as far as I ever ran. So I've been asked to talk to you about, knee pain and running, and we're going to focus a lot on anterior knee pain, but go over some of the more common causes of knee pain that you guys may encounter while you're training or running a marathon. We'll do a review of knee anatomy and then talk about risk factors, symptoms, treatment, prevention of various knee injuries, including patellofemoral pain syndrome, patellar tendonitis, osteoarthritis, and meniscal injuries. So first up is normal knee anatomy. The knee is a fairly simple hinge joint if you look at it on paper, but once you get into the nuts and bolts, there's actually several different articulating surfaces. A healthy knee joint obviously is the femur and the tibia, which is the major shin bone. The fibula is the smaller bone in the leg, and these all articulate with the patella or the kneecap. And what you see is they're mostly put together with ligaments that are holding them in place, your central, posterior, and anterior cruciate ligaments, and then your patellar tendon, quadriceps tendon also hold the kneecap where it's supposed to, or one of the factors that hold the kneecap where it's supposed to. And then in the central part of the knee, you have the kind of donut-shaped cartilage called the meniscus. And these are things that are all working in concert whenever you're out there on mile 22, hopefully not giving you too much trouble. You think about with running, tendons and cartilage tend to be affected most, more in overuse injuries. And then when we think about acute injuries, usually those are ligaments that are involved, although, there can be exceptions to that rule. So when you think about the articulation between the kneecap, the patella, and the femur, if that's not articulating well, that can lead to pain, and particularly something we're called patellofemoral pain syndrome that we're going to talk about in detail. Repeated stress and microtrauma of the knee running on hard surfaces or overuse can certainly lead to either quadriceps or patellar tendon inflammation called patellar tendinopathy. And then obviously anybody that's run extensively into their 30s, 40s, 50s, and 60s, we know that routine activities over time lead to the wear down of the soft tissue structures of the knee, particularly the articulating cartilage and meniscus, and that can lead to arthritis. With this group, I won't go into normal running stride and how that affects your knee pain, but it is important to know that obviously the more you're running, if that stride is not in a way that's more relaxed and certainly more efficient, it is going to cause you problems in the long run, and that's a whole different talk that we can get into. Patellofemoral pain syndrome is probably the most common thing that I see in our clinic, not only with runners, but just with athletes in general. It's one of the more common causes of knee pain that we see, and probably the most common cause of anterior knee pain, certainly in young active athletes. About 22 out of 1,000 athletes will get patellofemoral pain syndrome. About 25 to 30% of all sports medicine injuries that we see focus on anterior knee pain. This has a predilection for women over men for a multitude of reasons. But when we talk about patellofemoral pain syndrome, it's the pain at basically the surface of the knee, articulating underneath the kneecap or around the kneecap itself. Typically gets worse with squatting, running, or prolonged sitting. And the pain usually comes on over time without a specific injury or episode. So again, the definition is pain around or behind the kneecap that aggravates with activity. This is because there's a load in the patellofemoral joint while you're weight bearing on a flexed knee. So usually what I tell most people is if they're going from a sitting to a standing position over time, what we call a theater sign, you've been watching a movie for a couple hours and suddenly you get up and you have anterior knee pain, that's usually your patellofemoral joint telling you it didn't like that very much. The other common cause is running up or down hills. So if you're in a part of the city or wherever you're training and you're doing a lot of hill work, sometimes that can cause anterior knee pain and certainly can affect the patellofemoral joint. Occasionally, this may include a little bit of crepitus, what we call the kind of grinding and cracking that you'll get when you bend your knee, and everybody's knee kind of pops and cracks on occasion, especially as we age. But if that is accompanied with pain or an effusion, small amount of swelling, that's something that is also more concerning. So what are some of the risk factors? There's a lot, and really weak muscles. And these aren't necessarily weak, objectively weak, but weak in comparison to other muscles. So specific quadriceps muscle weakness, like the inner thigh muscle, the VMO, or hip abductors, certain tight muscles like hamstrings, hip flexors, or even tight quadriceps can cause this. And then certainly abnormal limb alignment, either having increased femoral anteversion, what we call kind of a little bit where your hips turn in, having knock knees, or excessively flat feet. All these things can contribute to your kneecap wanting to tilt outward. And this is a tracking issue. This is something that we see where the kneecap is wanting to kind of ride the rails on the outer part of the knee, and it becomes very, very painful when you do that a few times. And then when you do it a couple thousand times when you're out on a run, it becomes almost unbearable. So this overuse is from increasing training, sometimes too quickly, but it becomes a mechanics issue. One of the things that we look at when we're doing physical exams is to see if the athlete can hop on one leg. or do what's called a Trendelenburg test, where we have them stand on one leg. And if their hip abductors are strong enough to keep their hips level, then that can lead us away from patellofemoral pain. So what in particular do we do for patellofemoral pain syndrome? I would say if there's one take-home message, it's physical therapy, including strength, eccentric strengthening of the hip abductors and specific VMO strengthening is helpful for the long-term treatment of patellofemoral pain syndrome. You can do a lot of these exercises from home, doing slow and progressive training regimens. And then obviously, backing off of the things that are bothering it. If running hurts, and then, we're going to tell you to take it easy with running, and everybody knows that runners have to run. So normally I like to say, well, we can get you on a stationary bike or do other aerobic workouts that don't involve the same repetitive motion that are making this worse. Non-steroidal anti-inflammatory drugs, if you don't have any contraindications, can be very helpful, meaning taking a little Aleve or Motrin may help with this. And then, if that's not working, or we seem to be dealing with this long term, certain types of braces, McConnell taping, or foot orthotics may be helpful in general. And again, there's a bunch of different literature on this as to what helps more, but we try a lot of these things when we're trying to keep you running while you have patellofemoral pain, because it becomes a really difficult thing, especially late in training when we're trying to get this kneecap to track correctly. So, this is a multifactorial problem. And again, it's, all these things, if you follow the bottom up, hip muscles and hindfoot valgus and low back problems leading to core weakness that lead to tight hamstrings, that lead to dynamic knee valgus, meaning that the knee turns in while you're running through the full phases of running. This all contributes to patellar maltracking, and then increased stress on the patella and the structures, what we call the retinacular, the structures that hold the kneecap in place, and that causes overload and pain. So moving on, patellar tendinopathy, another really common cause of knee pain. They call this jumper's knee or patellar tendinitis in the short term. Again, if you look at the front of the knee where the kneecap is attached, the kneecap is a sesamoid joint or a sesamoid bone. So it's basically just sitting there. It's not attached to anything. It kind of sits inside the quadriceps and patellar tendons and just protects the front of the knee itself, the knee joint. And because of that, it has a lot of flexibility when your knee's in full extension. It doesn't have much flexibility when your knee is in flexion. And when you flex and you jump, it's pulling on that patellar tendon that runs from the kneecap to the top of the shin bone or the tibia. And in the short term, it can cause pain in that area, specifically with running, jumping, stair climbing, squatting. They call this jumper's knee. So it tends to be more with sudden movements, high impact movements, high stress to that particular tendon. And in the late stages, pain can occur not just with extension, but even with knee flexion. And usually when the patellar tendon is loaded, the pain occurs immediately, and then it subsides whenever they're resting. And that's the big difference between that and the knee pain with patellofemoral pain syndrome. So again, causes and risk factors. This is a condition that primarily affects athletes who play sports, who do a great deal of jumping or sprinting, may occur with acceleration or deceleration. So if you're doing a lot of hill workouts or you're running on hard surfaces, all these things can cause problems. Eventually, the inflammation part goes away and the patellar tendon can weaken or degenerate, and that's called patellar tendinopathy. And that is more of a long-term issue that can take much longer to go away. One of the common causes, again, include weakness in the quadriceps, hamstrings, gluteal muscles, and tightness in this area. And this overuse in physical training that is, again, too much, too fast can lead to any sort of tendinopathy, but specifically patellar tendinopathy. So what do we do? Again, first line treatments include strength training, stretching exercises for not just the knee, but for the hip flexors and the gluteal muscles and the core. And you're going to hear this as a general theme for a lot of physical therapy that we do for our athletes, because if you don't fix the underlying issue that's causing the stress on the knee, you're never going to get better. And so if you go, if you're seen by a physician who sends you to a good physical therapist and they start off working on your low back and your hips, you're wondering why they're doing that and not working on your knee. That's what they should be doing, and that's the sign of a good physical therapist. Physical therapy, again, is going to involve isometric and eccentric strengthening exercises, and then isometric and dynamic strength exercises. In an acute setting, short course of non-steroidal anti-inflammatories like Motrin or again Aleve can really help. Second line treatments such as platelet-rich plasma, again, remain investigational, but we do use that for a lot of our athletes. There's something else called 10X that we've tried that you can use for chronic cases that otherwise aren't getting better. There are particular straps or braces across the patellar tendon. It will provide some short-term relief, but again, it's not likely to assist in the tendon healing. And then the last thing I'll say is for any tendinopathy, we always ask if you're on any antibiotics, quinolone antibiotics such as Levaquin or ciprofloxacin. Those are medications that are really not great for athletes, specifically runners, because they can produce long-term tendinopathy, including tendon pain and even tendon rupture. So moving on to kind of the wear and tear part of the anterior knee pain. If you have patellofemoral pain long enough, you can get patellofemoral osteoarthritis, and that osteoarthritis can be anywhere. It can be in the femur, it can be in the articulating cartilage down at the bottom part of the knee, it can be along the kneecap itself. And again, this is one of the more common causes of joint pain, especially anterior joint pain in people over the age of 50. Classically, osteoarthritis is morning pain and mild stiffness that improves as the joints start moving, but then it returns with increasing activity. And then other symptoms include limitation of function, pain or rest at night, and then again, activity-induced swelling, knee instability, locking or catching sensation. And when the arthritis involves the cartilage behind the kneecap, it causes pain in front of the knee. And sometimes that pain can radiate down to the back of the knee as well. Again, the articulating cartilage is the protective kind of shock absorbing tissue that covers the bony surfaces within the knee joint. This arthritis or degeneration is just wearing out of the articular cartilage. And again, patellofemoral osteoarthritis occurs when the kneecap wears down. It's causing that maltracking. It can keep doing that over time, and eventually you're going to ride that rail enough to where it's going to wear down the articulating cartilage, and you're going to start to get more chronic pain. These risk factors for repetitive high impact activities include increased age. Again, females tend to have a higher predilection, and a family history of osteoarthritis. So again, mild arthritis can be managed with lifestyle changes, including weight loss, activity modification, and therapeutic exercise. Activity modification, includes relief during activity, and therapeutic exercise. So if we say, hey, listen, you can't run for a little while, we get you doing swimming or biking or maybe some yoga in the meantime, and allow you to do some things while we're getting you back to running. Bracing and certainly can provide bracing, or certain taping can provide some relief while you're doing physical therapy. And again, we talked about oral anti-inflammatories such as oral or topical anti-inflammatories or NSAIDs. We do not recommend opioids for chronic osteoarthritis, and injection options include cortisone injections, what we call hyaluronic acid or HA injections, and platelet-rich plasma. And the effectiveness may decrease as the arthritis becomes more severe. As you have less cartilage there, those things are going to become less helpful. Obviously, a knee replacement is indicated for severe arthritis that has failed conservative treatments. And there's a bunch of other treatments such as acupuncture, TENS unit therapy, local heat, and then glucosamine and chondroitin that have become less popular over the last 5 or 10 years. So again, we'll go over so one of the other significant injuries that we see is meniscal injuries. And again, this is something that's both acute and degenerative, and it can cause both pain in the front, the sides of the knee, or even in the back of the knee. But it is something that can commonly happen with runners and meniscal injuries. You know, the meniscus is this little donut-shaped cartilage inside the knee that can serve as a shock absorber. And for every step and you know, stride that you take in running, those meniscus are one of the things that help absorbing that shock. And one of the things with running strides is if you're a heel strike runner, I will say, and I won't get into the whole biomechanics tonight, but if you're a heel strike runner, again, it's what we know is that it puts a lot more forces that is transmitted up through the tibia or up through the shin bone and into the knee. So how you run is certainly a factor in whether or not you get some of these injuries. There's 2 types of meniscal tears, acute or traumatic, and then degenerative meniscal tears, kind of what I call the wear and tear part of it. These traumatic tears are most common in young athletes, and degenerative tears are usually seen in patients over the age of 40. Pain typically occurs in the medial or lateral aspects of the knee, although they can have pain radiating to the anterior knee. And symptoms include locking or clicking of the knee, especially with squatting, and delayed or intermittent swelling of the knee. So again, meniscal injuries, the risk factors and causes. Traumatic tears occur with sudden twisting forces or tears. So if you're trail running or running on maybe uneven surfaces and you take a bad step, this is where these can occur. Traumatic tears are most common in young athletes, but again, can happen at any age. Degenerative tears or meniscal tears, degenerative meniscal tears occur typically over long terms, you know, jogging or running, that cause tears that become, you know, the menisci that become soft and weak due to age and osteoarthritis. And again, we know people that are ACL deficient or have tears to some of those ligaments inside the knee that otherwise would provide stability. If you don't have that there, there's more translation forces throughout the knee that can cause these tears. So again, management depends on the type of the tear, the presence of mechanical symptoms, including like knee locking. When we say knee locking, the knee gets stuck and you can't move it. Somebody else has to, you know, wiggle your knee around to get it unstuck. The presence of persistent swelling, age, and of course, activity level. The presence of osteoarthritis or other structural damage like ACL tears can impact our management of these injuries. And then traumatic meniscus tears in younger athletes often require arthroscopic surgery to repair or move portions of the meniscus. Degenerative tears in athletes over 40 are usually best treated without surgery. And non-operative treatment consists of, again, rest, anti-inflammatories, physical therapy, and certain injections like HA or corticosteroid on occasion. Rehabilitation involves progressive weight bearing and increasing range of motion as tolerated. So with that, I'd be happy to take any of your questions. I know we kind of went through a few things, but we're getting close to 6:30, and I'm be happy to answer any questions you might have. And I again appreciate your time. Thank you very much.
Dr. Scott, thank you. That was really a great overview of the majority of the causes of pain in the front of the knee in runners. We do have some questions coming in through the chat. The first one is, would you recommend taking pain medication before a long run, or would that be harmful since it could potentially, mask the pain and any potential injury?
Yeah, that's a great question. And I think, what I tell most people is it depends on what you're treating and kind of where you are in your training. I try to tell my athletes and my patients not to get in the habit of taking medication to get through training or get through a run. And I that's one thing that I do have some experience personally with. I spent most of my college years, we called them ibuprofen sandwiches, and we would just take as much anti-inflammatory as we could to get through the day. And that was not a great way to train. It's not what I would recommend doing. But there are cases, certainly, when you can take short courses of anti-inflammatories to help the pain get better. in order to alleviate, what's going on. And I tell people all the time, you want to take anti-inflammatories like an antibiotic. You want to take it regularly for several days in a row, even up to maybe a week or week and a half, so that you can decrease the inflammation so that that decreases pain. Remember, anti-inflammatories are not like opiates or painkillers where you're going to numb the pain so much and go out and do something catastrophic to your knee, but it can be helpful. But when you stop taking them, there is some rebound inflammation that can occur.
Why is it that glucosamine and chondroitin sulfate seem to have become a little bit less popular in recent years?
Like most things in medicine, we've learned a little bit more, and glucosamine, to this point, the most recent study that I've read on glucosamine shows that it's really only helpful if you're taking pharmaceutical grade and pharmaceutical levels of glucosamine. So just getting it off the shelf from your local GNC or wherever is probably not going to be as helpful. It was not shown to be any better than placebo in several studies that came out in the last few years.
Thank you. Could you elaborate on why being female might put you at higher risk for anterior knee pain?
Yeah, and that again it's a whole separate talk, but very briefly, it has to do with mechanics. There's something called a Q angle, where the quadricep muscles come down from your hips, and when your hips are slightly wider, which they are with most females, and then come to a more narrow knee, that angle that then juts back out to the tibia. Again, when your quads are firing, those muscles fire and your kneecap wants to go in a straight line. And that can also cause this patellofemoral pain syndrome. So that's one of several different reasons, but that's the main reason.
Now, if I were to go out on a long run and have anterior knee pain following a run, how do I know when that's something I need to go seek medical attention for? How do I know when it's wait and see what happens, maybe take a few days off, versus, I should really get in and see somebody about that?
Yeah, and I think that's a great question. And of course, everybody knows their body better than anybody else could. So we all have been out on runs and said, hey, I just don't feel right today, or I feel a little off, or maybe I'm a little bit sore. I try to tell people to make sure that you're not running through pain, because that usually makes it worse. If you are exceptionally tired, or you had a really particularly hard workout a few days ago, mix it up a little bit, and maybe you go for a little bit easier of a run, or you do a bike workout or a pool workout. I find that those things are really, really helpful. And then when you do get back, you're running again with less pain, with better mechanics, and you're less likely to have a more significant injury. So to answer your original question, I say anything that's causing you to change your running stride or your gait, anything that's persisting for more than a few days when you're trying to train. I know everybody's getting ready to run this marathon in the next month. So, it's kind of crunch time for most people now, but it is something that when you're like early on in the training, 6 months out, you've got a little bit more time. You can wait and see a little bit longer. But as time gets closer to training or a race, I would get somebody to take a look at you sooner rather than later if it's bothering you for more than a few days.
Mm-hmm. Do you have any thoughts on CBD use for pain?
I don't have any good recommendations from a medical standpoint. I have patients that swear by it. What I will say is that unfortunately CBD is, it's kind of a mixed bag as to what you get. And even though it doesn't say that it has any other substances in there, some CBD contains more than just CBD. So you have to be careful with that. There was a great study about any supplements that they looked at just off-the-shelf supplements from GNC, and up to 25% of them had banned or illegal substances in them. So we tell most of our athletes, be really cautious about, for our professional athletes that are getting tested, be really cautious about what you're using because you really don't know what's in it. I tell people, if it works for you, who cares what I say? If you're not getting tested or you're a professional athlete and it seems to help and it's not otherwise harming you, who cares what I say? But I don't have any good hard evidence one way or the other for CBD.
Right. Now, there's a question in the chat, Dr. Scott, that I'm going to just step on your toes and answer myself. Someone asked, are there physical therapists who specialize in sports such as running? And if so, how do you find them? That actually happens to be my background. I'm a physical therapist, so I'm sure Dr. Scott would have a good answer too. But there are definitely physical therapists who specialize in treating sports injuries, and often there are ones who specialize in treating runners. There's a big difference between physical therapists. So if you do go to physical therapy, you definitely want to find someone who's really skilled. And if you don't have any recommendations, one of the easy things you can do to find somebody in your area is the American Physical Therapy Association offers a board certification for physical therapists in sports medicine. So you can actually go on their website and you can find out, who in your area is board certified in the area of sports medicine within physical therapy. So that's a good starting point. Anyone on this chat is welcome to reach out to me, through your Long Beach Marathon contacts. If you need a specific recommendation in your area, I'm happy to help you.
Yeah, I couldn't agree more. I think that's very well put. I will say that, the physical therapist makes all the difference in the world. And I tell people all the time, when you come in with a lot of these problems, don't, I'm not going to make you better as fast as a physical therapist will. A good physical therapist is worth their weight in gold. And there are physical therapists that I use that are specialized in dancers or specialized, certainly in specific sports, running, and certainly, other sports. So I find that, finding a good physical therapist, I'm up here in the Valley, but I think, certainly in the South Bay, there are some really strong physical therapists that know their biomechanics. And these are some of the more common problems that it's really easy for a good physical therapist to fix.
Dr. Scott, do you recommend the use of KT tape to help with knee pain during runs?
Yeah, so again, there's a little bit of mixed literature out there that KT tape or McConnell taping can help in the short run for patellar maltracking. Now, with that being said, how long that tape lasts or how long into your run is it going to be helpful? It is, I'm not so sure that it can be the end all be all. So at the end of the day, again, I'll go back to, if it's helping you and it's certainly not going to hurt, who cares what I say? If you feel like that it's helping you, then go for it. There has been some evidence to show that McConnell taping is helpful in the short run for patellar maltracking or knee pain.
Great, thank you. One of the questions in the chat, treadmills and track fields are probably better surfaces to run than concrete, but not always available. So what are some alternatives to running on the concrete?
Yeah, if you have a field, you can run in grass. I know it's, 120 degrees outside and we don't have much grass anymore, and certainly in the Valley, but I would say that not running on concrete as much as you can is helpful in the long run. I know a lot of people don't like to run on treadmills because it's just not the same, but I do find that, again, mixing up your workout so you're not doing the same thing over and over again is really helpful in preventing long-term injuries. So finding a softer surface, finding an all-weather track, finding a field where you can just go kind of run for a little while, all those things do make a big difference.
What are your recommendations for selecting a running shoe? And do you have specific insoles that you recommend for runners who overpronate?
Yeah, I again, this is kind of the first thing I'll tell you is I tell all my patients I'm a shoe snob. When I ran in college, we were contracted by Nike, and this is where I'll tell you I swear I'm not paid by any shoe company, but I don't particularly like Nikes. Sorry to anybody out there who works for Nike or is running in Nikes. I find that they tend to wear out a little bit more. They've gotten better over the years, but I find that shoes that have good hindfoot support, meaning that they, whenever you do come down with your natural stride, when you hit your heel has the support that it needs. So hindfoot support, and then remember, it's not one size fits all. So I'll answer your question by saying, go to a good running shoe store, have them look at your stance. Some people have really high arches like I do. Some people have physiologic flat feet that come back when you get up on your toes. Some people pronate, some people don't. You know, all those things, if you try, if you're otherwise not having pain, well, again, who cares? But if you can contribute to getting those arches up and make sure that you have an efficient stride, a good store, like out here in the Valley, we have, you know, Fleet Feet and a few other ones that are just good running shoe stores that can kind of measure your stride, measure your step, measure your foot, and then pick out a good shoe that's good for you.
Yeah, I would really echo, you know, what Dr. Scott said. I think it's really important to go to a specialty running shoe store that has knowledgeable people who work there, you know, and also find out about their return policy. Many of the high-end, you know, running shoe stores, they'll let you take, you know, buy a pair of shoes, you know, and keep it for 2 weeks, you know, as long as you're going to run inside or on a treadmill and not really muck them up, you know, and kind of try them out. And that's really worth its weight in gold. You know, shoes are trying to find a balance between flexibility and shock absorption and stability. And, you know, every foot type needs a different balance within that. So, you know, kind of consulting with someone who's knowledgeable to figure out what it is you need specifically is going to be really helpful. What about ice and heat, Dr. Scott? Do you recommend one or the other, you know, when you have an achy knee after a long run, or what is your take on that?
Yeah, so again, it's situational, and you know, I would not say ice your knee right before you go out for a 15-mile run, but cryotherapy has been shown to be helpful for alleviating certain types of pain, specifically arthritic pain. So for old knees like mine, if I'm having you know, some pain after a workout or something along those lines, icing is helpful. I always do say, you know, make sure you're not going to fall asleep with an ice bag on your knee, because I've seen plenty of frostbite in the clinic. And so maybe, you know, 15 to 25 minutes max is all you need for icing. If you're going to do a warm up, again, you know, dynamic warm ups, distance runners are notoriously bad about, you know, doing a formal warm up. But I do think that it can be helpful for preventing some of these injuries. And, you know, doing a little bit of heat before a workout, I think, is absolutely fine. Certainly we do that before physical therapy.
So while we're sort of touching on that subject of exercises, you know, specific to runners, are there specific warm-up exercises you recommend? And it's probably hard to go over strengthening exercises, but what specific muscle groups would you recommend that runners be targeting in a strengthening program?
I think the biggest problem that I see with a lot of runners, especially a lot of male runners, is hip flexibility. And one of the things that happens is, you know, we age, as we lose some of our flexibility in our hips. So you know, everybody can lean up against the fence and stretch their calves for 30 seconds and then go off on a run. And again, I've been there, but I find that as I've gotten older and I've got a 12-year-old that actually likes to run. He's a lot better runner than I ever was. And he'll go on a distance run. And if I go with him, I got to spend some time. I got to spend some time warming up. And I really do, you know, try to stretch out my hips as much as possible before I go. Everybody can, you know, do hamstring stretches and quads, but the things that we learned growing up, you know, sitting around before PE in a circle stretching cold muscles is probably not what we should be doing based on the literature. We really want to make sure that we're warming up well, you know, dynamically and getting our muscles warm. And then you can do a lot of those static stretches afterwards. But hip flexibility is probably one of the biggest things that I'd say focus on with some of the things that you're doing either before or after a run.
You know, and then probably additionally with a strengthening program, you know, it's the muscles around your hip, that really set up the rest of your leg to be in the right position when your foot lands on the ground. So, you know, really focusing on hip abductors, those are the muscles on the outside of your hips, you know, and the gluteus muscles and the hip flexors, I think is really important. You know, we think most obviously about strengthening the quad muscles, but we really want to, you know, set the leg up to be in the best position by getting the hips strong. Well, we're right now at 6:45, so I really want to thank everyone for joining us tonight. Everyone seemed to have really good questions. Dr. Scott, thank you for your time and expertise tonight. And we have recorded this webinar, and my understanding is that the Long Beach Marathon team will be, you know, sharing this with everyone after the fact. So I really appreciate everyone's attendance, and have a good night.
Thank you.